everybody. We have a guest today that's going to talk about cryptogenic stroke, and I need to go live for a couple of minutes, and she will come up on my list, and I will bring her on screen, and then we will get going. So we will, as always, as many times, I'm Mary Lee Nunley, and I'm the founder of United Stroke Alliance, or the start of United Stroke Alliance, which was Retreat and Refresh Stroke Camp, where we did camps for survivors and caregivers. And since then, we've added youth education on stroke, we've added strikeout stroke, we've added other arms of awareness, and we are kind of expanding, hopefully, into the business world with the signs of stroke. So that more people recognize the signs of stroke and understand it can happen to anyone at any time. So I'm just waiting for our friend Erica to join us. So if you're watching, say hi. I say hi. There is our friend Erica.
Hello.
Hi, Erica. Hi. That was so smooth. I love it. I love it. Love it.
Can we not jinx ourselves this early?
No, let's not. Let's not. My lighting is terrible in this dining room at this time of day. Hi, Candy. I've got not good lighting, and my ring light's not helping. Anyway, I cannot think of a better way to end the month than with this special guest, Erica Parker, who is an RN. Are you at Memorial Health University Medical Center?
Yes, I am in Savannah.
In Savannah, Georgia. So there we go. I'm going to have her do a little bit of an introduction and give us some history about how she landed in nursing and this particular vein of nursing. And then I've got a few questions. We're just going to chat a little bit. So you want to give us a little background, Erica?
Sure thing. Erica Parker. I have been a nurse now for almost 25 years. A lot of my history in nursing has been critical care, either emergency room, ICU. I did some flight nursing, but then I landed in angio, and that kind of led me to the whole interventional radiology, the thrombectomy program, which we started up at Memorial Hospital a couple of years ago. And it very much interested me in the stroke program in general. So when this position opened up, I decided that it was time to make a nice little change and be able to see my patients one-on-one and, you know, just track our program and look at the growth that we're doing and looking at how we're helping our community.
Very nice. Very nice. Okay. Well, the topic today is going to be about cryptogenic stroke and some of the treatment and diagnosis and treatment and such about that. So we've talked about this a time or two before, but for those that may be new to this or we don't always remember everything, can you go over a little bit about like how is a patient deemed to be cryptogenic? Kind of take us through the journey of it's not a clear, you know, ischemic or hemorrhagic stroke. And kind of what's the journey to the diagnosis in the very beginning?
So initially, of course, what we're looking at is like our initial head CT. So that's going to tell us right then and there if they're bleeding or if this is what they call an ischemic stroke. So basically some kind of blockage where the brain is not getting enough oxygen and nutrients to it for whatever reason. And for the most part, you know, we have our cryptogenic stroke pathway. So what we're doing is making sure that our order sets align with finding out the obvious causes for it. So we're going to be doing our TEEs. We're going to be looking for, you know, PFOs. We're going to be looking for the most common, obviously, being our atrial fib that's newly diagnosed. And that gives us a good indication that it's a cardioembolic stroke or what the pathway is. Now, if all of these things that we're looking at are turning up negative, then what we're thinking at that point is that we need to delve a little bit deeper into the cause of the stroke And for that, for the most part, what you're going to want to see is like your longer term monitoring for your cardiac, and especially the implantable cardiac monitoring, like with the Link device, because those things are going to pick up on maybe new onset atrial fibrillation that's not showing up when the patient is inpatient and on the telemetry monitor in the hospital. So these are going to be more of a long
Yeah.
term
What might the
monitoring.
time, yeah, the timeline, I mean, I know every timeline's different because every stroke is different, but is this timeline days, weeks, possibly months, or all of that?
I would say all of that, because the easy diagnoses are going to be in the first, day or so. So you
Okay.
can rule them in rather quickly. But the problem with cryptogenic stroke, or the challenge with cryptogenic stroke, is it's not always going to be apparent that it might be an underlying AFib just while they're in the hospital. That's why it's easier if you have something where somebody is monitoring their heart rhythm, somebody is checking in on this, and you can pick up those runs of AFib that a patient has that doesn't necessarily show up while they're still as an inpatient.
Okay. Yeah. Yeah. And that's, yeah. As I was saying to Erica before we came on camera, it was so, uh, helpful to me in working with stroke patients to finally understand a little bit about cryptogenic stroke, because there are people that are treated at hospitals or medical centers that they possibly don't get that all that information, or that information in an efficient manner, or didn't years ago before it was as easily detected and such. And so it's really nice, to be able to have another resource or another path for people to at least search, a little bit. So, um, so the cardiac monitoring, talk to us a little bit about the external versus the internal, because a lot of people that haven't had a stroke, they have the heart monitoring and they find out they have AFib, um, and nothing more, maybe medication or whatever. But there's a difference when the insertable device like the Link is something to be discussed. Can you talk a little bit about those differences?
Oh, absolutely. In fact, I actually wore a Holter monitor for a little bit. I was having like just these crazy, just I could feel it. My heart was racing, didn't know what was going on. So I actually got to live the Holter monitor life for a couple minutes.
Well,
And
all right.
yes, um, and I'm a fairly compliant patient. I'm very coachable, as I've been told. Like this is my background. But so for 2 weeks, I was wearing the external monitor, and it's much smaller than it used to be, and it's a lot easier. But I will tell you that it's still not ideal. I mean, it's just not one of those things that's easy to deal with, in the shower. You're trying to like not get it too wet. It can be up to a month long, but it's generally about a 2 week thing, but nobody's monitoring it in real time. So what you do is when you're done with it, you're taking it back to them. And then of course they have a physician that's looking over all your rhythms, and it's recorded everything, but again, it's not in real time. So um, there's a couple problems, especially where we see a lot of patients that are transferred into us. So having the patient be able to come back and drop it back off, or even mail it in, you're talking about a compliance issue, and just yeah. And I'm not talking about compliance in a positive or negative way, but the fact that it's not always that easy for somebody to turn that back in. And then
Mhm.
again, nobody's monitoring it in real time. So you're waiting a good little bit of time for turning it in, have somebody read it, and have them get back to you, and have them get back to your primary physician. All of these things can be a stumbling block. Whereas if you have the implanted cardiac monitoring device, especially if you get it done while you're still an inpatient, the fact that somebody is actually monitoring you the entire time, and they can tell if you've had events, and you can, well, and you can do this with both. You can record when you feel like you have an event. So you're pushing a button for the external device, but all of those things make it a lot easier for the implanted device to pick up on your arrhythmia.
So what would you say to someone if we've discovered that they have AFib and they've had a stroke, but they're reluctant? It feels like a surgery. It feels like you're putting something inside my body, and it's a foreign object in my body, and it's a surgery and such. So what would you talk to someone that's nervous about it? And while I'm saying this, if anyone has questions for Erica, go ahead and put them in the comments. I'll try and pay attention. But go ahead and talk about the anxiety someone might have with it being what it is, because it is a journey.
Absolutely. And again, this is where I think that my background in the angio cath lab and the EP lab has helped a lot, because I have dealt with patients that have that anxiety about any number of procedures. But I will say that this is absolutely the least procedure that's done there, if that makes sense.
It does.
It's not, you know, you're not being put under, you're not being, you know, even really for the most part sedated. This is like a local anesthetic that's delivered right there, and it's a small incision, and it's going under the skin. And one thing that we're working with Medtronic at our hospital about now is actually being able to do this at the bedside. And I think that that is a huge patient satisfier, only because then it doesn't feel like surgery. You're not taken to this sterile looking room. You're not put on the table, because for the most part, we don't even need, we don't need the fluoroscopy to be able to let us know that it's in the right place. You can feel the ribs, you know when you're implanted, and it's literally an under the skin situation.
That I didn't realize. Yeah. And so once it's there and the little incision is healed, is the person going to feel it? Can they touch and feel it? I've got a port for my chemo, and I can touch and feel it, but it doesn't bother me. It doesn't hurt. It's just a little bump under the skin. Is that similar? Or is it going to be deeper that they wouldn't be able to feel it on the surface? Just curiosity on my part.
Oh, absolutely. And actually, it's not. Hello, this is my son. Hey. He has no idea, but hey, we're on Facebook Live. So, sorry, I would have to say, like, if you look at the little silver part here of my pen, it is roughly that size, and it's roughly that length, and about, you know, the diameter and everything. So where you can feel your port, yes, you can feel this under the skin. But again, it's sitting under the skin, where your port is actually going into the atrium of your heart and all that. That part of the procedure, like this, is probably less, you can't see it on the surface as well as you can see it. Let's put it that way.
Okay. Yeah. So once that is implanted, then this is, we had some talking points, but this is me. Once that's implanted, and we're kind of talking about the link, that's the one we're most familiar with in our work, then someone is that information about what's going on in my heart is being monitored 24/7, correct?
Yes.
And where and how?
This is all going through, the way we're doing this right now is through like an iPad device. So basically this is uploading to them, but it's also uploading to the physician. And for right now, how we are handling it at our hospital is the physician that implants it is actually the one that is kind of responsible for it, as it were. So that cardiologist is going to be able to pull up any time frame and all the information with that.
So there's a receiving device outside that you have. so my husband has an ICD, so I'm assuming he has a little, looks like a small telephone that
Mm-hmm.
that is the device that transmits, because he has a heart failure, that transmits what they need. So it would be similar but different in that you've got a device that is powered up that that device feeds to.
Yes.
Somebody's
And what
monitoring.
we're yes, and what we're giving the patient is giving them the iPad that actually is what's monitoring
Okay,
them.
got it. Got it. That makes sense. That makes sense. Um, what are some of the common questions you get from patients that are in this on this journey of potentially getting an implantable device? What are
Well,
some standard things?
the standard things are going to be that, they're worried about how long it has to stay in, how long is it going to be before somebody gets back in touch with them, how does this all work for them. And I think that what we rely very heavily on is the Medtronic rep that works with us, that goes and actually sees the patient and gives them all the information, explains who they're going to be following up with, explains like the whole, and I hope I'm saying this right, like the care link that's actually following them. So they give a lot of the information as far as the long term, what's going to happen with the patient. What we handle in house is a little bit more, is it going to hurt? How long is the
Right.
procedure going to
Sure.
take? Can my family come with me? Does my wife know about it? Does my husband know about it? Like those kind of
Yeah.
things, which
Mm-hmm.
I think, again, when we're looking at implanting it at the bedside, it will be a huge satisfier because the patient doesn't feel like it's this, you know, huge surgical thing. The family's there, the family can ask questions, everybody can do things in real time.
Yeah, it takes some of the drama out of it. Yeah.
Exactly.
How long, and how long that you posed a question I've never asked. How long does it stay in? Is it indefinite? Does it stay implanted indefinitely?
I mean, it can stay in for a couple of years, but for the most part, once they are seeing what they need to see, then they can get it removed.
Got it. Okay. And then they can move forward then with whatever treatment is appropriate to manage whatever needs to be managed. And
Exactly.
that's as different. We know every stroke is different. I'm sure every patient is different with what they need and what's going on within their body as well.
Absolutely.
Yeah. Oh, if anybody has any questions, put them in now. I'm going to see if Erica has any more thoughts that come to mind of something that she maybe has seen, or a story or something that she would like to kind of wrap up with.
I will say that now that, with the crystal AF studies and everything that we have been looking at here recently, we are looking at now the fact that, cryptogenic stroke can also be a large vessel occlusion as well as a small vessel occlusion. So another thing that we're trying to implement at our hospital right now is getting the cryptogenic stroke and the loop recorder involved in the LVO cases as well as the small vessel occlusions. So,
Tell us what LVO is.
sorry, our large vessel occlusions. So those are the
Okay.
ones that we're taking in for the thrombectomy. So where we work, the angio suite is where they are doing the thrombectomies, which is
Okay.
right next to the EP lab. So what we're trying to do is have those physicians in touch with each other. So when they're getting an LVO, it can bounce to the EP physician so they can put a recommendation in for them to get a loop recorder, the link device
Okay.
being a loop recorder, within their hospital stay. And I'm seeing an increase of people actually getting these done while they're inpatient, which of course is going to increase your compliance with that.
Absolutely. Absolutely. It's always more difficult to get somebody back.
Absolutely.
You get home, you start feeling a little bit better and you question things, and it's
Mm-hmm.
starting all over again is more difficult than continuing a series of treatment in that.
Yes.
Yeah. Yeah. Does anything else come to mind, Erica? Nobody's posting any questions right now.
I really think that that's about all.
Yeah.
Without
Well,
any questions.
Yeah, that was a great overview, and I learned if you, I mean, I've talked to others about this in the past, but this was some new information, and it seems that it shouldn't be frightening. I guess what I'm thinking is really shouldn't be anything that someone's frightened about or resistant to, because
Absolutely.
it has a huge benefit. Huge benefit. Yeah,
And
absolutely.
that's our biggest point with it, is just making it a little less intimidating for the patient,
Hmm.
for the family, and so somebody can have actually some concrete information by the time that, you know, by the time that they're following up again with their physicians. And that way,
Right.
if they need to go down the pathway of being on anticoagulants or whatever the case may be, it's all about preventing that next stroke. Most of our
Um,
education.
I do have one more question that just popped into my mind. Are these only for individuals that have had a cryptogenic stroke? They are not for someone that has AFib that has yet to have a stroke. Am I correct on that?
You are correct on that, as far as I am aware of. And now
At this point, yeah.
you have to understand my
Well,
background is going to be the stroke part of it. So I
right,
know that people
right,
do get loop
right.
recorders, like for people that have syncopal episodes, like any number of
Yeah,
things. There's other
right.
reasons for it, but as far as for the stroke portion of it, yes, it would be after they've had a stroke and there is no
Yeah,
defined reason.
yeah. That's what I've always thought. But then all of a sudden I thought, well, sometimes, and it may change. That may change.
Hmm.
There may be some modifications. I mean, things are changing so fast in medicine, and we're so blessed to have so many options and so much good care. Um, we just have to be more aware of it. So, well, thank you so much for taking your time away from your three children. Any thoughts that's popped up that you thought you overlooked? You good?
Nope, I'm good. Thank you so
Okay.
much.
Thanks everybody for tuning in. We really appreciate it.